So one of the things that changed my perspective on hydraulic sinus elevation were two things. One was a novel grafting material that's a putty using NovaBone. It's an alloplast, not a xenograft and not an allograft. And it is a phosphosilicate material that resorbs at about 50% over the first 5 or 6 months. So we published an article on this back in 2012, over a decade ago, and we were quite fond of the utilization of this material for extraction sites. This material, as a putty, in combination with Versa drills, which I'm going to talk about in terms of osteodensification, or what they call a V-lift, a Versa lift, has really expanded my ability to treat these cases using a vertical crestal approach. So here's the article we published with George Katsakis, myself, and some of my colleagues. This was published in JOMI. And when we compared this material to a bovine bone mineral material, this had superior qualifications to be used. It resorbed at a nice pace. It was easy to apply. It had a great applicator tip. And it started to focus and start to get us to think of how else can we use this really great and unique material. At about the same time, or a year later, Ziv Mazor from Israel and his group published what he called the minimally invasive crestal approach technique. And when you look at it, he basically used the NovaBone system, their cartridge delivery system, as one of the highlights of his article, meaning that without it, this is not something that he would perform. So he would either place the implant simultaneously or do it staged, and he would use the hydraulic pressure from the cartridge delivery system of the NovaBone particles to push the sinus up with the putty. And here is one of the cases that was highlighted in the article. You can see a beautiful area here where you have sort of a little mushroom or dome that's created past the floor of the sinus. That was all done through this Mitse technique using the NovaBone and hydraulic pressure. The Mitse technique, MITSA, was the acronym, minimally invasive transcrestal sinus augmentation, was introduced by this group. They recommended a 3 millimeter osteotomy be created at the ridge, and then placed the cannula of the NovaBone dispenser, which is only 2.8 millimeters, which would fit intimately inside this osteotomy, allowing only the bone putty to be introduced vertically and not to come out through the crestal access. So after breaching the sinus, they use the piezo first with the Hipse technique, with that water spray that I showed you earlier, and then they push the putty in as needed. The precise fit of that NovaBone cannula into a 3 millimeter osteotomy allowed this to be done with great ease and great accuracy. And one of the most important aspects as well was they looked at their cases and said, for each 1 cc of NovaBone putty, you got 10 millimeters of a lift of the Schneiderian membrane. So we go ahead and we place the cartridge and the applicator tip into the osteotomy, and we push that hydrodynamically into the sinus. Once that is done, we slow down the RPMs to 150 RPMs, and we go in with the 4 millimeter drill at very slow RPM. And what that does is it pushes the bone that we've placed, the NovaBone, and it pushes it laterally and apically to create this little dome effect that you're seeing in the right radiograph. At that point, since we have at least 3 millimeters of crestal bone, we can stabilize the implant. We can go ahead and simultaneously place our implant into this area. All of this done with a very, very small access crestal incision. No large lateral window, no additional cost of membranes and tacks, and with a very, very small amount of bone. Typically with a lateral approach, I'm using at least 2 grams of bone, and with a crestal approach, I'm typically less than 1, sometimes a half a gram.